Good morning. Thank you, Aditya, for this invitation. We have 15 minutes left. I think there are 3 more talks. So let me know when I have to stop. I'm just going to show maybe 2 or 3 techniques with the time limitation, which can be helpful. As Dr. Coker said, there is technology, there are techniques. In strabismus, there are no much of technology other than imaging. It's mostly the technique which we have to. So I'm going to put maybe few of those if possible, if the time permits. First one I just wanted to say is something like graded superior rectus transposition. We all do SRT for monorectus transposition for either Duane syndrome or even 6-nerve palsy. What this video shows is you have an option of doing a graded superior rectus transposition, which this is from the Boston group. I think Linda Daggy has done it. I feel it's quite interesting. You can see we can put a suture at 8 millimeter, we can put it at 10 millimeter, we can put it at 12 millimeter. And if you mark at 12 o'clock, where at the end of the video you can see that, you can see the change in the intorsion. See that? That's changing. The 12 o'clock and 6 o'clock mark, it changes. I think this can be used in severe cases of Duane syndrome or even 6-nerve palsy. So this way you can change the effect. You can see pre-op there was 4 cyclotoxin, and then after transposition there was 5. First augmentation you can see 7, intorsion. So this is a graded one which can be utilized in our day-to-day. Personally, where do I use it? In a very severe 6-nerve palsy, instead of 8 millimeter, I go 10 or 12 depending upon the severity. That's the first thing I just wanted to. One more of our colleague, Dr. Kraft, they have looked at, SRT is the standard treatment for Duane syndrome now, plus medial rectus, and then SRT and medial rectus is what 90% of us do now. How it is compared with, myopexy sutures, you just similar to Nishida kind of thing, full tendon transfer with the Foster. Only thing is you transfer the thing, and they have looked at what is best. You can decide for yourself what is best in your thing. Since Kraft has a paper on this, this is where he has added resection also. And you can see the post-operative thing in this series of cases, and also post-op abduction. You can see probably this gave him the best, but we don't do it in every patient. I just thought that for yourself, you can decide what works best in your case. That's why I just wanted to share this. Something local, the Namaste sign, we can use it. It's a very simple tool to make your superior oblique tuck. We don't do superior oblique muscle surgery in superior oblique palsy unless it's a lax muscle. Whenever it is lax, people use superior oblique tucker that's available. People measure it, but as we are discussing is one of the fellows, we thought that you just have to do this mechanical approximation. It's a whole case is described here. I just want to forward it. So what we really do is you identify the superior oblique muscle on the superior-temporal approach. This is the superior rectus muscle being hooked here. You can see sometimes our retinal colleagues just cut it off. So, and also in glaucoma surgery, it can be cut off. So be careful. We know how valuable it is. We do even 1/3 in a Haradaito. It's very, very significant muscle for us. So whatever laxity you look at, and then this has to be a full Namaste. People do this Namaste. This has to be full Namaste. So with that, it's a simple thing. You can do it. You can utilize in your day-to-day practice. Simple technique of the Namaste sign for this. The base has to be approximated completely. 3-step test been doing. We have been teaching residents all that. there is a masquerade here. It's not always superior oblique palsy. In this case, this is the superior oblique, this is the superior oblique. Pretty easy. With the image, you can really correlate. And when it is normal, still it behaves like this, you have to see what are the other masquerades. Acquired superior oblique palsy, congenital, acquired masquerade, and congenital. What is being done is imaging versus your 3-step test, how it is correlating. I would not go into the detail because of the time factor, but you need to think about 4 conditions: sagging eye syndrome, acquired Brown syndrome, very, very rare cases, or CCDD, which is congenital. So these are the 4 masqueraders you can, but I don't know about panel. I also see thyroid eye disease masquerading as superior oblique palsy. If you don't pay attention, this is one more thing I would add to the list, because this study is published. I'm just putting what the study said. And the last thing I just wanted to share, maybe 2 videos of oculomotor palsies. This is from my friend Federico Vélez from UCLA. Superior oblique transposition, described way back in 1977 by Scott. He's no more. It's a brilliant pediatric ophthalmologist. And also caruncle fixation, already described. That's why I said these techniques have been already described. Sometimes it resurfaces after 30 years or 40 years. This is what happens. This is the caruncle fixation. I think I have a surgery, video here. Just trying to fixate it to the caruncle. You can fixate it to the medial wall also. This is a caruncular fixation, which gives a very good result. You can see in this, this is the pre-op. This girl has a limitation there. See the medial rectus. And this is somehow on the first post-op day. You can see it improves, the range of movement improves. It's not really perfect. We can't expect complete movement. So that's about caruncular fixation. One of the concern people ask is, even in plication, we all experience that bump remains for a few days, but it becomes flattened over a period of time because it really fibroses after a few days. The last one is limited adduction and abduction. I think it's a simple tool like the first one I shared. This is the preoperative because it's type 1, but there is a type 2 component also because it's downshooting. You can't really make out there is a adduction limitation. Obviously, it's almost an immobile eye. So what is being done is Y split with modified Nishida. This, I think, some of the patients, we can definitely use it in our practice, where after splitting the lateral rectus into 2, Y split, you can also do a modified Nishida, where you can bring the superior rectus there. You can improve the range of movement because there is downshoot taken care by Y split, abduction limitation taken care by the modified Nishida. So I think personally I feel it's a cool technique. This is first post-op, but you can see an improvement. You can imagine on the first day. But I think logistically everywhere it makes sense in this patient. That's all I wanted to share. Thank you so much.